guys, this is Alicia with Good Morning Sunshine. So today again we had 4 lectures. I still awaiting on lab. My lab's at 3 to 5, so that kind of sucks, but another long day. We've had 4 lectures this morning, one including bacteriology. I do have the PowerPoint for that, but I feel like if I threw that in there, I haven't been doing lecture talk on bacteriology just because it's so hard because we usually don't have the PowerPoint. This time I did because I switched professors for it in order to go over. So one went over gram-positive bacteria, and now this one's going over gram-negative bacteria. But I'm not going to bring those in, so I'm going to focus on 3 lectures today. We had clinical pathology. We also had regular animal pathology, and then we had virology as well. I'm going to start with clinical pathology 7. So we went over leukograms and neutropoiesis. So we're going to talk about white blood cells now and neutrophils. So the WBC is the total white blood cell count. When this is increased, that's known as leukocytosis. And then osis, the ends in osis usually means increase, the same with the if it ends in philia. So for white blood cells, we have leukocytosis, so that's the increase in white blood cells, and then we have leukopenia, which is the decrease in white blood cells. We also have lymphocytes, so that would be increase in lymphocytes would be lymphocytosis, and then decrease would be lymphopenia. And then we have monocytes, so we have monocytosis for the increase in those, and the decrease would be monocytopenia. He said that these are not really clinically relevant. But then we have neutrophils, and that would be neutrophilia. And then for the increase, and then the decrease is neutropenia. And then for eosinophils, it's eosinophilia. And then eosinophopenia for decrease. And then we have basophils. Again, basophilia is the increase in basophils, and then the decrease would be basopenia. He also said these ones weren't relevant either. So then we have relative versus absolute counts of white blood cells. So we would do 10,000 microliters, which equals 10 times 10 to the 3rd power. And then we have a relative differential count, which is percentage. He said this was meaningless to us. This is per 100. So, but in order, we have to get the percentages right. And then in order to come up with the absolute number. Oh, my dog's coming. I'm getting her. Sorry, Marie wanted to come up and see me. Yeah. My grandma can't hear either, so. Anyways. So then we have the absolute differential count, which is also per microliter. This helps us with determining an underlying disease, which the relative count would not. So basically we times, so if we have neutrophils, and this equals 60%, and the lymphocytes are 30%, and the eosinophils are 10%, we would just times that percentage by 10,000 in order to get the absolute differential count. So those would be 6,000, 3,000, and 1,000. So neutrophils are 6,000, the lymphocytes were 3,000, and the eosinophils are 1,000. And then we have the corrected white blood cell count. So that's known as the CWBC. So we can either get an absolute count by an instrument, but sometimes this instrument may fail us because it may identify nucleated red blood cells as leukocytes. So when the white cell count from the laboratory or the instrument is wrong, or there's like a weird high number, this is because it's including the nucleated red blood cells. So we usually want to ask if they're including the nucleated red blood cells in this count or if they aren't. So falsely increased nuclear red blood cells, we would have to do a manual calculation that way. So in order to get the corrected white blood cell count, we would do the white blood cell total count times 100 divided by 100 plus the nucleated red blood cell count. So here's just so I can show you, that's our formula. So if we get an outrageous number like 125,000 when the reference interval is supposed to be between 4,000 and 14,000, sometimes that indicates that we need to do it manually. So we would do that formula in order to calculate the right amount. So then we have impedance count, which is the white blood cell count. Impedance count, it is termed the WIC. So it's the W WBC count must be corrected. So this has to do with the pulse of electricity. So that was what I was talking about. And then we have the optical count, which is the white blood cell count, is termed WOC. This is the white blood cell count, does not need to be corrected. So this has uses a laser for counting. So these are like different instruments used. So here he gave us another example. So total white blood cell count from an analyzer. So this is what he gave us. So we got the relative percentages, but again, you would times that by whatever number they give you. So here we got 20,000 per microliter. So we would then times it by 20,000 in order to get the absolute white blood cell count. So then we went over neutrophil kinetics. Now we're into neutrophils. So the bone marrow, that's 5 days. It yields to blood, which takes about 10 to 12 hours, and then it yields to the tissue. So proliferating happens in the bone marrow, so does maturation. So proliferating is where you would have a myeloblast, a promyeloblast, and then a myelocyte. But then these mature and become a metamyelocyte, a band, and a segmenter, which then the neutrophils are released into the blood and then into the tissue. The blood has a circulated and marginal part. So again, here's our pyramid. I'm going to show you. Here's our pyramid here, what I was talking about. So the pyramid is to represent all the cell types. So if a cat bite happens, so signals happen, and then you get the expansion of precursors that finally arrive at the blood, and then the last place they end up is in the tissues, where to get fixed. So it takes about 5 days for every part to be signaled in this pyramid. So the largest component there is a storage pool. The proliferation pool is the first purple segment here, so that is the more triangular segment up top. You can't distinguish between the cells here. The myelocyte gets secondary granules, and this allows for differentiation. After the myelocyte stage, you can tell a metamyelocyte from the others, so that's when you can start distinguishing between the cells. So we have normal recruitment of neutrophils. So we have a mature neutrophil, which are released first, and then it goes down the line, so dipping into the deep reserves. So this is known as degenerative left shift. So there's 3 pools in marrow maturation. But you start with the neutrophils first, and then you go down the line as each pool gets, I guess, not deleted, but they run out from each pool. Also, you shouldn't see metamyelocytes in circulation. That would be a problem unless there are bands. So the neutrophils are out first into the blood, like I said, and then it goes down the line. So then we have a circulating pool, like I said, in the blood. So this is counting total white blood cell count. This is what we use when we take blood samples. But then we have a marginal pool, which are stuck on the vessels, and these aren't used for the testing of blood. If there's increased blood pressure, such as excitement, we can go from the marginal pool to the circulating pool. This is dramatic in cats, which have the largest marginal pool. Cells only stay in a vessel for a short time. The neutrophils upregulate and help them adhere to the endothelios to get to where they need to go. They spend little time in the tissue. They are just there for the chemotaxis. And then degenerative left shift equals overwhelming inflammation. So now getting into the neutrophil left shift, so what I've been talking about, this means inflammation basically. So here's a band neutrophil when I was talking about bands. So here's the myeloblast, here's a promyelocyte, and then there's the neutrophilic myelocytes, and then the neutrophilic metamyelocytes, which you don't want to see in circulating blood. And then we have the band neutrophil and the segmented neutrophil there. So regenerative left shift, this is just usually said as a left shift, not they leave out the regenerative part. So CBC findings for this is a mild to moderate left shift accompanying a neutrophil. Its significance is the bone marrow is responding to tissue inflammation and releasing earlier neutrophils from the maturation pool. And then we have a degenerative left shift. CBC findings here is the immature neutrophils are greater than the mature segmented neutrophils. So we get neutropenia based on segmented neutrophil count plus a left shift. The significance here is the bone marrow cannot keep up with the peripheral demand for neutrophils, so it's interpreted as overwhelming inflammation and often suggests a poor prognosis. So this is bad. And then we have a deep left shift, which is a left shift with the presence of neutrophil precursors earlier than banned neutrophils. And toxic neutrophils that yield inflammation, this is known as cytoplasmic. And then we have the maturation defect, which is second to inflammation. This is rust and means direct toxic injury. These effects occur in order. So we have a diffuse cytoplasmic basophilia. This is due to a greater amount of RNA, a mild diffuse cytoplasmic basophilia, but this can be normal in cats. Then it goes to the Doyle bodies, which are blue-gray. They're amorphous or angular cytoplasmic inclusions. It reflects stacks of retained endoplasmic reticulum. There's 1 to 2 small doily bodies, and this can also be normal in cats. Then down the line, it goes to toxic vacuolization, which is the indistinct or frothy cytoplasmic vacuoles due to dispersed organelles. So this is not to be confused with discrete round vacuoles caused by prolonged exposure to EDTA. I feel like I need to cough, but I can't cough. I don't know. Sorry, guys. So then we keep going down the line. We have toxic granulation. This is dust, like purple to dark, pink cytoplasmic granules. And then we have a donut-shaped nucleus, which is rarely noted. The nucleus is round with a hole in the middle. So hence donut-shaped. And then going down the line, we have a giant neutrophil, which is rarely noted. A neutrophil is larger than normal in size. We have severe of toxicity. Minimal to mild toxicity is 1 or 2 of the most common morphological features. We have moderate toxicity, which is usually 2 of the 3 most common morphological features. And then we have severe toxicity, also known as marked toxicity, where all 3 of the common features and or toxic granulation. So here's normal morphology. And then we have cytoplasmic basophilia. That's what that looks like, what I've been talking about. And then we have the Doyle body here. We have the cytoplasmic basophilia. This is Doyle bodies in the vacuolization state. And then we have a toxic granule there. So we have neutrophil infectious agents. Infectious agents looks like berries, he said, or mulberries. We have Anaplasma phagocytophilum, and then we have Ehrlichia species. We have distemper inclusion, which are round distinct inclusion, mostly in erythrocytes. And that's what these look like here. So that was our clinical pathology lecture. Was that ClinPath? I think it was. Yes. So then we got into DNA viruses 1, so virology 4. So this was our discussion about DNA viruses of veterinary importance. So we have the herpes virus, also known as herpes viridae. So we have infectious bovine rhinotracheitis. And then we have equine rhinopneumonitis and also Ajewski's disease. And then we have feline rhinotracheitis, and then canine herpes virus and malignant catarrhal fever. And then we have some others. We have S. viridae, which is the African swine fever virus, which is going on right now. And then we have Hepatitis viridae, which is a woodchuck hepatitis virus. And then we have Pox viridae, which is orthovirus. We have bovine papular stomatitis virus and lumpy skin disease virus that go with these. And then we have Adenoviridae, which is infectious canine hepatitis. And then we have Papillomavirinae, which is canine. We have canine, bovine, and equine in these. And then we have, of course, the Parvoviridae, so parvovirus. So we have feline, the feline one, the pig one, which is porcine parvovirus. And then we have the Latin mink disease. And then we have Cercoviridae, which is the, again, porcine circovirus, which porcine is pig, associated disease. So herpes virus, starting with that, is range in size from 200 to 250 nanometers in diameter. It is double-stranded DNA viruses in a icosahedral capsule or capsid. It enters cells by fusing with the cell membrane. Key concepts: through the herpes virus is usually infected at a young age and then it becomes latent. So it stays like dormant in our body basically, and then it will flare up at times of stress. So this virus replicates in the nucleus of the host cells. It's seen histologically as internuclear inclusion bodies. It becomes latent in sensory ganglia. Animals will be subclinically infected, and clinical disease manifests in times of stress, like I said. It is labile in the environment, so close contact is needed for the transmission of this virus. Quarantine can be an effective method of control, so biosecurity is definitely important for this virus. We have the alpha herpes virus. So those key concepts are: it infects the epithelial, which is the skin, the mucous membranes, the tracheal mucosa, the liver, the brain, the GI tract, and the lungs. And it also infects the endothelial cells, which line the blood vessels. So it's an active infection, results in cell death. So we can get ulcers, which is the breach of the basement membrane, and it can only heal by scarring. This has to do with the skin part. We can also have erosions, which rub off the epithelium but do not breach the basement membrane. These are for the mucous membranes. And then we have hepatocellular necrosis. This has to do with the liver, and then vasculitis has to do with endothelial cells. And then we have the bovine herpes virus 1. We have alpha herpes virinae. We see this with a lot of cows shipped to feedlots. But there's 3 subtypes of the bovine herpes virus 1. We have BHV 1.1. This is a respiratory and reproductive part. And then we have 1.2, which has to do with genitals, so infectious pustular vulvovaginitis. And then we have, again, 1.2a and 1.2b. 1.2a has to do with abortions, and then 1.2b has to do with no abortions. But the one we're going to focus on, I think, is BHV 1.1, so bovine herpes virus 1.1. So it has aerosol transmission, so nose-to-nose contact. It doesn't live well in the environment. The virus replicates in the mucous membranes of the upper respiratory tract. It becomes latent in the trigeminal ganglia. It is reactivated in times of stress. Large amount of the virus are shed in nasal secretions. It has strong immunity develops, but secondary bacterial infection can result in severe disease. So respiratory disease, it causes rhinitis, tracheitis, which is inflammation of the trachea, and predisposes to secondary bacterial pneumonia because of the inflammation of the trachea. And then the bovine, this is known as bovine respiratory disease complex. Also causes reproductive disease, so viremia in pregnant cows. An infection of the fetus results in abortion. We have a multifocal hepatic necrosis in the fetus with intranuclear inclusions. So this is what infectious bovine rhinotracheitis looks like. So we have an necrotizing tracheitis there, and then on the left we have an ulcerative dermatitis, so the red nose. So the herpes virus 1 subtype is for both of these, and what it can cause. It can cause the infectious bovine rhinotracheitis as well. So IBR, this is the sacral bacterial bronchopneumonia, which can happen also. This is the lungs of an animal infected with IBR, so firm lung loads, it's cranial ventral where the bacteria falls. So we have consolidated cranial lobes in this picture. And this was the secondary infection I was talking about because of the inflammation of the trachea. Here's herpes virus abortion part. So we have the multifocal necrosis in the liver here. The hot picture, this is a fetus that was aborted. And then here we have the liver multifocal hepatic necrosis with internuclear inclusions of what it would look like on hematology. So this is the color difference in the hepatocytes. This is also known as pignosis, which means the shrinking of the nuclei. So you probably can't see in the camera, but there's 2 different colors here. Here's normal, and then over here is not normal. So then we have equine herpes virus 1, also known as alpha herpes virinae. There's 2 strains. There's the EHV1, so again, EHV means equine herpes virus. So EHV1, we have D752, and then we have N752. So the entity, the N, which yields the D, we start with the N, and then it's caused by a single nucleotide chain. So a single nucleotide chain results in more severe diseases, so it's more pathogenic and affects not just the epithelial now, it affects the endothelial now. D752 of this equine herpes virus is respiratory, so we have rhinopneumonitis, and for reproductive we have abortion as well, and neurologic. For the N752 we have respiratory, reproductive, and non-neurologic. So equine rhinopneumonitis is EHV1 and EHV4. It has to do with aerosol transmission, nose-to-nose contact. The virus replicates in the mucous membranes of the upper respiratory tract and regional lymph nodes. It becomes latent in the trigeminal ganglia, so just like the other ones. These are basically all the same, just in different animals. It's reactivated in times of stress too here, and large amounts of virus are shed in the nasal secretions like the other one. And for respiratory disease, you have rhinitis, tracheitis, and it may extend to the lungs, especially in young animals, which then it could have a secondary infection like pneumonia. And then reproductive disease, ramia and pregnant mares results in abortion again. And then EHV1 has a predilection for vascular endothelium resulting in placental vasculitis and thrombosis, multifocal hepatic necrosis in the fetus with internuclear inclusions. But with equine herpes myeloencephalopathy, which affects the spinal cord and brain. So it's typically associated with the D strand, so the D752 strand. It follows an outbreak of respiratory disease or abortion on the farm. The neurological form is reportable in Virginia to the state veterinarian. Vasculitis, necrosis, and hemorrhage in the spinal cord and brain. That's what it means. So here's the spinal cord here. We have the fixed spinal cord segments with hemorrhage in the gray matter here. Then we have canine herpes virus, and it's Seymour in puppies because they are cold, so they can't replicate. So healthy don't show clinical signs because they only replicate in colder environments. They do not like replicating at normal temperatures. So here we have aerosol or in utero transmission, so through the placenta. The virus replicates in the mucous membranes of the upper respiratory tract, the pharynx, and the tonsils. It becomes latent in the trigeminal ganglia. It's reactivated in times of stress. Large amount of the virus are shed in nasal and vaginal secretions, so replication is most efficient in temperatures below body temperature. So that's why adults are okay, whereas the young are not. Canine herpes virus, pups can be born infected, so neonatal pups are most susceptible, especially in the first 3 weeks of life. If the dam is infected within 3 weeks of whelping, the puppies will be infected through the placenta, so the entire litter may be affected here. The morbidity and mortality are high. The dam will develop immunity and subsequent litters will be unaffected. So they can lose a whole litter due to this, the mom can, but this will only happen once because then the mom becomes immune to it. This is what this would look like in puppies. So here we have a multifocal interstitial necrosis in the lungs. We also have a multifocal hemorrhage in the kidneys here, and then we have a multifocal hepatic necrosis. And then we have a feline herpes virus one, also known as feline viral rhinotracheitis. It also is aerial transmission, so nose-to-nose contact. The virus replicates in the mucous membranes of the upper respiratory tract and the conjunctiva. It becomes latent again in the trigeminal ganglia. It's reactivating in times of stress, and large amounts of virus are shed in the nasal secretion. So nothing different there. This virus for cats accounts for 40% of respiratory diseases in cats. It's acute upper respiratory tract infection. It includes sneezing, hypersalivation, and conjunctivitis. It can lead to ulcerative keratitis, which means ulcers on the cornea of the eye. Secondary bacterial infections can result in pneumonia. And then we have the porcine, which means pigs, herpes virus 1. This infects other species. So if the pig gets it, it can spread it to any other species. At least they cannot spread it to humans because it's not zoonotic. It has to do with a bite, so getting bit by a pig, also known as a Jenski's disease. And then known as pseudorabies in other species. PHV, also known as which is porcine herpes virus 1. It's the only one of these alpha parasites that can infect other species, but it is not zoonotic, like I said. Pseudorabies eradication has been successful in U.S. swine herds, but wild pigs may still be infected by this. So your Jeschke's disease, or the PH1 virus, has aerosol transmission as well. However, you usually have to get bit by a pig in order to get this. The virus replicates in the epithelium of the oral pharynx and tonsils. It spreads to regional lymph nodes and the brain via the cranial nerves. It becomes latent in the trigeminal ganglia. It's reactivated in times of stress. There's a large amount of virus. It's shed in the nasal secretions, milk, and semen. Its mortality can reach about 100% in suckling pigs. Neurological signs predominate in young pigs. Infections of sows can result in abortion with hepatic necrosis and intranuclear inclusions in the fetus. Pseudorabies and other species manifest as severe neurological disease and pruritus, and there's death within a few days. So comparing and contrasting, reproductive, respiratory, neurologic, and become latent, shed in times of stress is how all of these things are the same. All these viruses are the same. However, different categories. Cats are not usually associated with abortion. Dogs, neonatal death doesn't replicate well in the body. Temperature, so puppies cannot thermoregulate well. That's why it's more common in puppies than it is in adults. Pigs, it can be transmitted to other species. And then horses, the neurological form infects endothelial cells. And then we have gammas, herpes viruses, key concepts, which infect lymphocytes. It produces latent infection in lymphocytes, so that means too many lymphocytes, and can cause neoplastic transformation. We also have malignant and cardiac fever, which is no clinical disease in these. When it gets in susceptible hosts like bison, it's bad. So the species I'm about to say to you, they don't have clinical disease. These are our natural ones. So we have the ovine gamma herpes virus 2, and it is sheep associated. And then we have the alcephine gamma herpes virus 1, which is in wild beasts. And then we have caprine gamma herpes virus 2, which is goat associated. So these have these viruses, but it doesn't affect them. However, when the virus get into like cattle, deer, giraffes, pigs, and bison, then it's a problem. So again, there's no clinical disease in natural reservoir hosts. However, severe disease can occur in susceptible hosts. So a transition between susceptible hosts does not occur. So reservoir host to susceptible host, that's how it occurs, but you can't go between susceptible host to susceptible host. So a cattle can't infect a deer because those are both susceptible hosts. But the goat up here, which is a natural reservoir, can infect a deer. So the sheep shed large amount of virus during lambing. Clinical signs in susceptible hosts depend on the species. So we have vasculitis, hemorrhage, and primary necrosis of the epithelium. We have corneal edema, so blue eyes. We also have mucopurulent nasal discharge. We have gastrointestinal and bladder hemorrhage. And we have neurological disease, cutaneous disease, and fatal lymphoproliferative disease. So this is what malignant catarrhal fever looks like in the eye. This is corneal edema. And then we have this pure vascular inflammation, so necrosis in the wall. Lymphocytes are affected by the virus. And then we have the vasculitis here for hematology. So we have the thrombus here. We have pure vascular inflammation and fibrin and necrosis. So that was our virology lecture. And now ending with pathology 8, so animal pathology. We're talking about chemical mediators of inflammation, of acute inflammation. So we have cellular here, we have liver. They have different mediators, many different mediators, and then they come from different sources. So starting with chemical mediators of inflammation, they're cell-derived mediators. So they have vasoactive amines. So this is such as histamine and serotonin. We have arachidonic acid metabolites. We have nitric acid or oxide, also known as NO, and then cytokines. And then we have plasma-derived mediators as well. So that has to do with the complement system. So starting with the vasoactive amines, so histamine is present in a preformed state in the mast cells being tissue cells, basophils, and platelets in the cytoplasmic granules. It can be released instantly as needed. Mast cells typically are found in connective tissue near blood vessels. Histamine is released So degranulation in response to physical injury, so heat, cold, or trauma. Also immune reaction, so IgE binding, so this is type 1 hypersensitivity, which I've talked about before. And then we have the presence of complement fragments C3a and C5a, so anaphylotoxins. It can directly degranulate mast cells. So the actions of histamine are the dilation of arterioles. It increases vascular permeability of the venules, which causes endothelial contraction in these venules. Serotonin acts just like histamine. It's just a different cell type, so it has to do with platelets instead. It is, again, performed in platelets. It's released in response to platelet aggregation. So again, actions are similar to histamine in acute inflammation. And then we have arachidonic acid metabolites. So AA metabolites. So we have a phospholipid bilayer that's degraded and releases eicosanoids. There are two primary classes of these. They have which are known as prostaglandins and leukotrienes. Those are the classes of the inflammatory metabolites of the eicosanoids. The eicosanoids are products of AA metabolism, and they regulate inflammation and homeostasis. So again, we have the arachidonic acid metabolites and inflammation. So we've done this cycle before. We have a cell membrane phospholipid. The phospholipase degrades phospholipids. This creates the arachidonic acid, which then creates cyclooxygenase and 5-lipoxygenases. The NSAIDs are the ones that only inhibit cyclooxygenation, whereas steroids inhibit both the lipoxygenation and the cyclooxygenases. But with NSAIDs, they inhibit then the production of prostaglandins, which is all said in this cycle. So again, steroids inhibit basically phospholipases, so arachidonic acid is not even made. So again, that cuts off cyclooxygenase being made as well as lipoxygenase. Whereas NSAIDs are here where they only they are COX-1 and COX-2 inhibitors, but they only have to do with this side of this pathway. They don't have to do with the lipoxygenase. It's only the cyclooxygenases. So again, arachidonic acid metabolism. Corticosteroids, again, inhibit the action of phospholipase and the production of the arachidonic acid. So again, that's steroids. And then the cyclooxygenase pathway has with prostaglandins. The prostaglandins are produced by cyclooxygenases. So you have COX-1 produced, which is constitutively expressed all the time, and then COX-2, which is inducible, so it's upregulated and needs to get induced. But this includes PGE2, PGD2, alpha, PGI2, which is prostacyclin, and then TXA2, which is thromboxane. So aspirin and non-steroidal anti-inflammatory drugs, also known as NSAIDs, like ibuprofen, phenylbutazone, they inhibit the cyclooxygenase, so COX-1 and COX-2, and inhibit synthesis of prostaglandins. Again, the activity of lipoxygenase is not affected by NSAIDs. So then we have the lipoxygenase pathway. These are enzymes that produce this enzyme produces leukotrienes and lipoxins from the arachidonic acid. Leukotrienes include chemotactic for leukocytes, and it has vascular events such as vasoconstriction, which increases vascular permeability. The lipoxins inhibit inflammation, so inhibit leukocyte recruitment and cellular components of inflammation. Then we have nitric acid, also known as NO, which is produced by endothelial cells, macrophages, and neurons. It is synthesized by nitric acid synthase. It has two functions in inflammation, so it has vasodilation, which contributes to vascular reaction. It inhibits cellular inflammatory response, so it reduces platelet aggregation and adhesion, so it's anti-inflammatory, and inhibits leukocyte recruitment, which is also anti-inflammatory, so anti-chemotactic. As a free radical, it kills microbes, so nitric oxide kills microbes. The functions of nitric acid: it has a wall of blood vessels with endothelial cells. Enos, it's reduced adhesion and reduces leukocyte adhesion, so EN OS here. But then we have INOS, which can also be in macrophages. This reduces the nitric oxide, which is released into the blood vessels. Then we have cytokine mediators. So cytokines are polypeptides produced prevalently by macrophages and lymphocytes. Its primary action is modulation of activities of other cells. The main cytokines involved in acute inflammation are IL-1, so that's interleukin-1, and TNF, so tumor necrosis factor, but mainly TNF-alpha. So actions of TNF and IL-1, so inflammation starts. This results in the activation of sentinel macrophage. It increases secretion of IL-1 and TNF. This upregulating the expression of leukocyte adhesion molecules. There's also the production of IL-1 chemokines. They increase coagulant and decrease anticoagulant activity. Also, there's an activation of leukocytes and the production of cytokines. This all having to do with inflammation. So here's the chart here of everything I just went over. So again, you have inflammation starting, you have the activation of macrophages, which yields TNF and IL-1. And then these lead to local effects as well as systemic effects. So you have everything I went over here for inflammation because that's what we're learning about. But you also have local effects such as fibroblasts, which is proliferation and the increase of collagen synthesis, this having to do with repair. But then we have systemic effects as well, which yields for fever, leukocytosis, increased acute phase proteins, decreased appetite, and increased sleep. This having to do with the systemic manifestations of inflammation here. And then we have chemical mediators of inflammation, so cell-derived mediators. So we have vasoactive amines. Again, we have histamine and serotonin. They're arachidonic acid metabolites. We have ROS, the nitric acid, NO, the cytokines, and the plasma-derived mediators, so the complement system. So we're now going to go over the plasma-derived mediators complement system. So these mediators, again, are complement. They are defense against microbes. They have the formation of a MAC, so a membrane attack complex. And then complement activation causes increased vascular permeability, chemotaxis, opsonization, and the main components are present as inactive plasma precursors. So again, the activation and function of the complement, it can be activated in many ways. So we have a lectin pathway, we have alternative pathway, and then we have a classical pathway. So all of these pathways cleave C3. So C3b is deposited in the microbe for all of these. This then gets recognized of the bound C3b by the phagocyte 3CB receptor. Then there's a phagocytosis of the microbe. This is known as a classical pathway. But then we have a lectin pathway. So again, the C3b is deposited in the microbe. This happens for all the pathways, and then this creating the formation of the membrane attack complex, also known as MAC, and this leading to the lysis of the microbe. That's the lectin pathway, but then we have an alternative pathway where the C3b is again deposited on the microbe. The C3a is released. Then there's the recruitment and activation of leukocytes, this leading to the destruction of microbes by leukocytes. So the classical pathway is an antigen pathway, whereas the alternative pathway has to do with microbials, and then the lectin pathway binds to mannose, but has to do with lectins. So again, going over that in simpler terms, so we have the plasmin proteases complement, so the activation of the complement. So the classical pathway is the reaction with IgG or IgM containing antigen antibody complex. The alternative pathway is contact with microbial surface and polysaccharides, so the cobra, venom, and endotoxin, whereas the lectin pathway has to do with plasmin mannose binding lectin binds to microbes. The initial steps in the complement activation lead to the formation of an enzyme, so C3 convertase, which cleaves C3. The C3 cleavage leads to release of C3a, so the anophylotoxin, and then the covalent attachment of C3b initiates formation of C5 convertase. So the formation of C5 to 9 is the MAC complex. And then we have complement-derived mediators forming during cleavage. So we have C3a and C5, which yields and facilitates histamine release from mast cells, so vasodilate and increases in permeability, so aka the anophylotoxins. C5a activates lipo-oxygenase pathway of the AA metabolism in neutrophils and monocytes. It's chemotactic for neutrophils, monocytes, eosinophils, and basophils. But C3b yields and acts as opsin Opsonins, when fixed to bacteria, they facilitate phagocytosis by neutrophils and macrophages receptor. So that was the end for pathology here. And again, I'm not bringing in bacteriology because it would just really confuse you guys. Because I just have the PowerPoints. I take notes on the PowerPoints. I don't have like a Word document to go through with you guys. But it's very cold here. Also here's Mermy. But yeah, we're wearing big jackets now. It's like 30 degrees in the morning and my windshield's frozen. So I'm now having to start my car in the morning. But luckily I have a push start, which is very nice. So I can start it from inside and it'll turn on by itself and turn on the defroster for my frozen windows, which is very nice. But yeah. So just have one class tomorrow, which would be nice because we have to get to studying, but I really need to finish my posters I did the posters for, parasitology, but now we have viruses in the mix and also bacteria in the mix. So I'm just very confused and this test might kill me, literally. But anyways, we're on the countdown now. It's November 4th right now. I will be in, actually, I'm not going to say, but anyways, I'll be seeing my girlfriend as well as my brother in roughly 2 weeks. So that's gonna be nice. But yeah, and I think that was it. I think that's all I wanted to tell you guys today. But anyways, I hope you guys have a good Thursday today. And I still have lab, so I have to do that. But right now I'm gonna do some more work and get stuff done before I head back to lab. But I love you guys.